My name is Agam Dewan. I'm a board certified psychiatrist, and I've helped over 200 PMHNPs and FNPs gain clinical confidence in their psychiatric diagnosis skills, treatment skills, and helping them help their patients get better. So, in this video, we are going to be covering questions to ask a new job, and specifically a private practice job. So, if you're a new NP and you're looking for your first job, or you've worked in the field for a while and now you're deciding, okay, what kind of job do you want to go to, and you're leaning towards a private practice job, there's probably a bunch of questions that you want to ask your employer to make sure that the job is a right fit. So, for example, my last job that I was in, first job after residency, it seemed good for at the little bit, but over time, it turned out that it was not the best fit for me, and so that's why I ended up leaving. And then now I'm doing my own thing, and so that's why I want to educate you on that as well, so that way you know what to look out for in case you are trying to start a new job. So there's 10 things I want to go through with you. So let's get right to it. So number 10 that I want to say is the educational aspect. How much education are you actually going to get from this job? So a lot of the NPs that I work with, they say that when they sign up for their job, they were promised that, yeah, the collaborator is going to teach them, yeah, the other psych NPs or providers are going to teach them, but then turns out that they were all busy doing their own thing, and so they barely got any education. And so imagine being a new NP and you're starting this job, you think you're going to get a lot of education, especially because there's no kind of residency like there is for medical student graduates, that it's guaranteed. So now you think that you're going to get education from this thing, and you don't. So you're left floundering on your own, seeing 20 patients a day, trying to learn it all on the fly while keeping up with the demands of seeing patient back to back. It's really quite overwhelming. So that's why asking what the educational requirements or the educational teachings are and how it's brought into the private practice is a very important thing and should not be underemphasized. You can even ask the other providers too what kind of education they receive. Never hesitate to talk to another person there. But you definitely want to ask about that. Number 9, something you want to ask about is the admin. How much admin support are you going to get at this job? So when I was in residency, I worked in practices where I had to handle I scheduled the patients myself. Any kind of thing the patient needed, like social work or therapy referral, I would put in. If I needed to order labs, I would put in. Any kind of paperwork, like disability paperwork or etc., I would handle. So it's a lot of admin time that goes on the provider's docket, especially if you have patient after patient added in. And then when I worked at my last job, which was private practice gig, there we had an admin assistant. And so my admin assistant handled my emails, patient messages, paperwork, getting referrals for things, coordination of care. So it freed up a lot of time on my plate because the admin assistant was able to do all that work. And so that made a huge difference for me and my work personally. So how much admin support you're going to get is very, very key and should not be neglected. Like you could take a job that pays less if for example, their admin support is stellar. Number 8, what I want to cover is the patient population. So I've worked in private practice settings that are more community mental health based, like Medicare, Medicaid patients. I've worked in a residency clinic where it was just kind of like the average person going in just using regular commercial insurance. And I've worked in a concierge private practice where people would pay multiple thousands of dollars for evaluations. And so we saw a higher socioeconomic status bracket. And so each of those populations came with their own challenges. For example, the lower socioeconomic, the community mental health, so their challenge was that they couldn't afford a lot of the ancillary resources. Following up was very difficult in those cases. They were just very severe and they needed more support than the average outpatient provider could get them. So that's why they had ACT teams and support teams. And then the diagnoses that we'd be dealing with were different too, like schizophrenia and bipolar. I was using a lot of long-acting injectables for the community mental health. Then in the the standard mental health, kind of like commercial insurance, so that was just straight bread and butter psychiatry, seeing a whole bunch of outpatient conditions, not really so much as schizophrenia, but just depression, anxiety, ADHD, that type of thing. So very standard stuff. Most, by and far, most of the patients were, they had homes and jobs and financial support and that kind of things, but they weren't rich by any means. And then I worked in a concierge private practice where there, the patients were, wanted more immediate answers when they would send messages. They had higher expectations of the staff and the clinic experience. I found that they were the most, I guess, needy or demanding patients, were the higher socioeconomic patients. They wanted more like a supplement care as well. So like I learned how to use supplements and natural ways to treat, not just pure medication management. So that was key thing there too. So yeah, there's definitely a distribution in, the patient population. And, for that higher level patient population, this higher socioeconomic status one, it was a lot of the worried well, and sometimes they thought there were issues that weren't actually issues. So that's why there's a large discrepancy. So that's number 8. Number 7 is marketing. So in any private practice, it's a business. And so the business needs revenue, and they get the revenue from patients. Patients need to know about the business. So different practices may ask providers to be a part of the marketing. So I didn't get this in my residency experience or my community mental health experience, but the concierge private practice that I was working for, they had a requirement where they wanted their physicians to get involved in marketing. So I was making social media content for them, which I wanted to do, but I was also attending, like they would have these like dinner sessions or like meet and greets where people could come to the clinic. And so I would be staying up, staying late, right, not getting paid, doing this marketing stuff. I would be giving some like talks and Q&As to other communities that were out there, to therapist office, again unpaid as well, because part of the expectation was that I would be assisting with the marketing team. And so like I wanted to do that, like I was happy to do that, but it's additional time that you're not being compensated for. And so if you're not really interested in that business aspect of things, then that may be a drawback for you. If you don't want to market, you just want to clock in, do your work, and then leave. Number 6 is call. So what are the call responsibilities? How does that work? Are you responsible for your patients even off the clock, or is someone else going to handle them for you? For example, when I worked in the residency clinic, we had a like an on-call resident person who would take all the after hour calls. But then when I was in my concierge private practice, then you're the one, like any kind of patient issue goes to you. But I had an assistant who would like filter through some of the requests. So some practices may also want you to be on call with inpatient hospitals as well. And basically how you handle patient issues outside of the standard like 9 to 5 or whatever, you want to ask that, because that's additional work that you're not going to be compensated for. So you want to ask about how it works and the volume of requests that you get too. So that's that. So number 5 is insurance. Now, every place that I've been to, at least, they've covered the malpractice insurance. However, you still want to check that. You want to make sure that it is covered, and they don't expect you to get your own malpractice insurance. Or if they do, that's fine, but maybe they'll recompensate you for it, or they will. Yeah, you just got to know what the expectations are. Super, super key with the insurance things. So number 4, kind of going back to the patient population, but the visit structure. So evals versus follow-ups. So for example, when I was at my community mental health clinic, the evals were 45 minutes to 60 minutes long, and the follow-ups were all 20 minutes long. So contrast, and then when I was at my residency clinic, the evals were an hour long and the follow-ups were 30 minutes long. Whereas I was at my concierge private practice, the evals were 2 hours long and the follow-ups were 30 minutes long. So you see how it can differ the amount of time you get. So you want to find the adequate, the right balance, because if they're too, let's say they're too short, then you're not going to be able to do the patient justice either, right? Like the evals, I thought were a little too short. The community mental health, where it's 45 minutes, but that's because they have so much volume and not enough providers, so they need to do that. Whereas other places, the evaluations are 2 hours long, which sometimes can be a little bit longer than you need to. And then if the evaluations or follow-ups are too long, then that's time you could have been wasting seeing another patient and getting more revenue out of that. So just understand what the visit structure is too. So number 3, documentation. So documentation, super, super important. Oh, one more thing to add actually regarding the visit structure is no-shows. What their no-show policy is, very important. Some places they will charge the patient for no-shows, other places they won't. So if they charge the patient for no-shows, then at least your time gets compensated for. But if they don't charge for no-shows, then if a patient doesn't show up, then you're shit out of luck. Now you just wasted half an hour, right? Congratulations. And that'll get to later down, but the no-show I'll expand on a little bit more. But you want to ask about what the no-show policy is. So number 3 is documentation. So with documentation, you want to find out how onerous the requirements are. I've worked in places where they were very minimal, but I've worked in other places that had you write on pretty much like full-on essays for the patient or for the documentation. I remember when I was working in the emergency room, they had the worst EMR ever, where you had to go through and check through all these little different things, including the mental status exam, and then all this extraneous fluff that they'd put in. And it was such a chore. It took just as much time to do the documentation as it did to see the patient. And then one thing I'll add here is AI. Are they going to allow you to use AI? Do they provide an AI software to use? Because AI in my private practice now has considerably cut down the time I spend with admin tasks like documenting. But I've had students in my program, for example, they say that AI documentation is not allowed. So for whatever reason. So you definitely want to assess the documentation, what the EMR is, and how onerous those requirements are. Super, super important. Number 2, so telehealth / in-person or hybrid. You want to find out what the structure is that you're going to be working. Is it a telehealth practice? Is it all in person? Is it hybrid? Nowadays, I'm seeing hybrid is the most common model, but there are places that are a lot of telehealth, and then some places are only in person too. So that makes a huge difference. For me, I strongly prefer telehealth. So that's why that's what I do in my private practice. In the last practice I was in, they actually, which was kind of a detriment, they actually preferred in person, but they did telehealth if the patient wanted it. But they were really pushing, encouraging us and the patients to go in person. And so for me, at least that became of a chore to go there to the office. And especially if you have 1 or 2 patients that day, or if you had, I remember when I was doing my child fellowship, our outpatient year, I would have, let's say, all telehealth patients and then 1 patient who was in person. And so we'd have to go up for that in-person patient. And then sometimes it would cancel. And so I literally would have wasted a trip there for no reason. So that's why, this matters more than you think. And remember that you get paid the same whether it's telehealth or in person. So in person, you're wasting more time than with telehealth, with the commute and things. But some patients prefer that. Some providers prefer this. So finding out what the structure is and aligning that to you. For example, for me, I don't like in person, just that's how I am. And so that's why I don't work for a hospital system, because that's an in-person gig. And I just don't like that type of work environment. But that's what you got to figure out. It's your life. So you have to figure out what makes you happy. And then number 1, last but definitely not least important, is the pay. Obviously, how much they pay you, but also whether it's W-2 versus 1099, because this will differ with your taxes. W-2 is a salary position. 1099, you're a contractor. So that's that. And then paid salary vs per patient. So for example, when I was doing residency and fellowship, those were all salary positions. So meaning that if I saw 2 patients or 10 patients a day, I get paid the same. Versus my last concierge private practice was per patient. So with this, I get paid based off of the how many patients come in. So if a patient comes in, then I get paid, but if they don't come in, I don't get paid. I got paid 50% of what the patient paid. So the split, so that's another thing with the pay. So I've been part of 50-50. I've seen some of the NPs in my program, they've had 70-30 splits, where basically the practice was like 70 and they get 30%. I've had NPs in our program say that they just offered him a flat salary of like $100 an hour, and then of course per patient too. So understanding the payment structure, very, very important, because you don't want to get shafted. You worked hard to get here, and so the amount of compensation you receive is important. I think in the academic field, in the healthcare field, we're taught to not talk about pay so much. We're greedy providers if we're thinking about money, but that's all a complete load of horseshit. Ignore all that. Pay is important. You worked hard to get here, and don't let anyone tell you that. So that's another tip. So the reason they feed you all this stuff, don't be about money, and don't be greedy and you're a healthcare hero, is because they want to pay you less. That's why in COVID they didn't give a lot of providers bonuses. Instead, they fed them, oh yeah, healthcare hero, because it's a lot. If I'm an admin, it's a lot easier to feed my employees hope and positive praise than it is to feed them money. Never, never, never neglect that. But yeah, those are the questions to ask if you start a new job, private practice. And so if you really want to understand how to practice real world psychiatry, I've built my own private practice, how to build one, how to scale one. I cover all that stuff in my PMHNP coaching program as well. And of course, how to do well with patients, understanding psychiatric diagnosis, psychiatric treatment, and really becoming the best provider you can be to get rid of imposter syndrome. If that interests you, you can check that out. And otherwise, I will see you in the next video.